Chapter 25, the Spine. In this chapter, you will learn about the anatomy of the spine and injuries to the neck, low back, sacrum, and coccyx. We will also cover the basic concepts of evaluation and treatment as we discuss each condition. Please use the presentation to guide you in your reading. There are 33 individual vertebrae in the spine that originate in the neck, cervical spine, becoming the mid-back, thoracic spine, then the low back, referred to as the lumbar spine. Finally, the sacrum, which is 5 fused vertebrae that make up the pelvis with the 2 hip bones, and then the tailbone, referred to as the coccyx. Only the cervical, thoracic, and lumbar vertebrae are considered movable or true joints. The sacrum and coccyx are false vertebrae fixed by fusion. Notice the curves in the spine. God designed these to tolerate the stress that occurs from being upright and mobile. The neck and low back are considered convex anteriorly, and the thoracic and pelvis are convex posteriorly. There are discs that lie between each of the cervical, thoracic, and lumbar vertebrae. The function of the disc is to act as a shock absorber for the spine to protect the vertebrae and spinal nerves. Imagine a small water balloon filled up with toothpaste. This is the makeup of the disc. The outer layer is very firm and fibrous. This is the annulus fibrosus. The inner portion is gelatin-like semi-fluid. This is the nucleus pulposus. The joints begin to degenerate with age and injury. The result is a less flexible, less fluid-filled disc. This causes degenerative changes in the spine, and the vertebrae become closer in proximity to each other and to the spinal nerves. This can cause pain. This fact also explains why older people lose their height. One of the reasons is because their spinal discs are degenerating. Another interesting fact is that you are taller in the morning than in the evening because of the changes in disc height. The muscles of the spine are quite extensive and consist of both deep and superficial muscles. Use this presentation and the chapter to guide you in your reading in this area. Imagine large bundles of electrical wires that travel from pole to pole. They carry a lot of energy and impulses. These wires then branch off from the main line to each of our houses where they bring us electricity. This is a similar analogy to the spinal cord and nerves. The spinal cord is the main electrical wire that brings impulses from the brain to the rest of the body. The spinal nerves are smaller ones that branch off from the spinal cord and provide movement and sensation to specified areas throughout the body. In a catastrophic spinal cord injury, the individual loses sensation and movement below the area of the injury. If the injury occurs at the C1 or C2 level, the individual may stop breathing and need the assistance of a ventilator. Many of these injuries are also catastrophic. So in a cervical spinal cord injury, the individual will lose feeling and movement in the arms and legs. In a lumbar spinal cord injury, the individual will lose feeling and movement in just the legs. There are 4 primary movements to the vertebrae. These include flexion, extension, lateral flexion, and rotation. When you bring your chin to your chest or touch your fingers to your toes, this is considered flexion. When you tip your chin up and look to the sky or arch your back, this is considered extension. Bringing your ears to your shoulders or your shoulders to your hips is considered lateral flexion. And finally, looking over your shoulder or twisting at your waist is called rotation. Refer to the textbook for a complete description of the injury prevention strategies for the cervical and lumbar spine. Evaluating the spine is comprehensive and complex. Refer to the textbook to gather additional information. However, for the purposes of this class, we will discuss the major injuries that occur in athletics, with focus being on the primary treatment offered by the coach. A spinal fracture can occur from extensive flexion with axial loading, such as receiving a force to the top of the head. This occurs primarily in football players when they drop the head before a tackle, or for a diver who hits her head on the diving board. The athlete will complain of pain in the neck and possible numbness, weakness, tingling, or inability to move the arms and legs. It's imperative that you do not move the athlete and immediately implement your emergency action plan. If an athlete is unconscious, you should treat him or her as having a neck injury until it is ruled out by a physician. Treatment in the hospital will consist of dosages of steroids and the placement of a halo brace for immobilization. Surgery might also be performed if a bone fragment is compressing against the spinal cord. A cervical sprain, also referred to as whiplash, occurs from forceful flexion and extension of the spine. This is a common car accident injury. When the car is rear-ended, the head propels forward into flexion. When the car suddenly stops, the head recoils back into extension. In a sense, you sustain two injuries in this scenario, with soft tissue in the front and back of the neck being stretched. Pain and spasming are the common signs and symptoms. Muscle spasming is a protective response to prevent the muscle from being used. Refer the athlete to a physician for evaluation and diagnosis. A soft cervical collar may be used. Ice is implemented for 2 to 3 days. Analgesics and anti-inflammatory medications may also be prescribed. In time, head and massage with mechanical traction or chiropractic adjustments may be used. The spinal cord and nerve roots are injured in 5 basic mechanisms: laceration by bone fragments, hemorrhaging, contusion, cervical cord neuropraxia, which means a severe twist or a snap of the neck, and spinal cord shock. Refer to the textbook for a complete description. The signs and symptoms correlate with the level and extent of the injury. Spinal cord injuries may be complete or incomplete. A complete lesion is when the spinal cord is totally severed and there is a complete loss of all movement and sensation below the level of the injury. An incomplete lesion is when a portion of the cord is injured and symptoms correlate with that area. Management is the same as for cervical fractures. Use extreme caution. Do not move the athlete and implement your emergency action plan. Brachial plexus neuropraxia is also referred to as a burner or a stinger. The mechanism of injury is when the neck is forced laterally to one side when the shoulder is depressed. The bundle of cervical nerves, known as the brachial plexus, are stretched. This happens most often in football and is referred to again as a stinger, burner, and pinched nerve. The athlete will experience immediate pain, numbness, and burning into the hand. In most cases, these symptoms are temporary. Treatment consists of ice and confirming that the symptoms are completely resolved before the athlete returns to full activity. The athlete should strengthen and stretch the neck and shoulder to prevent future injuries. Properly fitted shoulder pads and a cervical neck roll can also be used. Fractures to any vertebrae are not dangerous because of the fracture, but because of the risk to the spinal cord. Compression fractures are the most dangerous and occur from a serious hyperflexion or falling from a height and landing on the feet or buttocks. Signs and symptoms include pain, numbness, and loss of sensation or strength in the legs. Again, it's important to implement your emergency action plan and not to move the athlete. Treatment consists of possible surgical intervention to stabilize the spine. Excessive extension contraction and faulty posture are the two most common causes of sprains and strains. Signs and symptoms include pain in the low back with possible referred pain into the buttocks. However, sensation and movement in the legs are normal. Ice packs and bracing are helpful in the first few days of injury. Strengthening, stretching, massage, and chiropractic treatments can assist with proper alignment and healing. Back contusions occur with significant impact to the low back. The athlete will experience pain, spasming, and point tenderness. You must determine the location of the pain. If the pain is directly over the spine, then a fracture must be ruled out. If this is the case, implement your emergency action plan. Be reminded that the kidneys are located in this region, so it's important to further evaluate the athlete for pain upon urination and also to determine if there is blood in the urine. If these are present, refer the athlete to a physician for further evaluation and treatment. Sciatica is an overused catch-all phrase that refers to any pain experienced in the low back, through the buttocks, and into the thigh. This inflammatory condition occurs from chronic low back problems, including disc protrusion, vertebral compression, and tightness of the piriformis muscle. Notice in the presentation the piriformis muscle. The sciatic nerve, which is the bundle of lumbar nerves that travel into the legs, lies under this muscle. When the piriformis muscle becomes tight, it compresses the nerve, causing pain. Please refer to the presentation of the video clip demonstrating the appropriate way to stretch a tight piriformis. Try the stretch and feel the deep pull that occurs in the hip. Lumbar discs experience constant stress from faulty body mechanics and trauma. Hyperflexion and rotation are the most common mechanism of injury. The movement pinches the disc and causes it to either bulge or to herniate. The pain is the result of the disc compressing the spinal nerve or spinal cord. Symptoms of numbness, weakness, and bowel or bladder difficulties may also be present. Initial treatment includes pain-reducing modalities such as ice and electrical stimulation. Traction and joint manipulation can also be used to provide comfort. The ultimate goal of treatment is to reduce the disc protrusion and restore normal posture. Core strengthening and stretching exercises are important to stabilize the area. Oftentimes, the symptoms will reduce with time. However, if there are signs of nerve damage, surgery is warranted. The sacroiliac joint is where the ilium of the hip meets the sacrum. It is joined by strong ligaments that allow little motion. However, it can be strained from multiple mechanisms that include twisting with both feet on the ground, falls forward or backwards, misjudging a step and landing heavily on one leg, locking the knees with forward bending, and lifting. It's also prevalent in downhill runners and sports requiring repetitive unilateral or one-sided activities. These activities can produce irritation and stretching of the sacroiliac ligaments. Symptoms include pain and point tenderness over the joint. There may be referred pain into the thigh and groin as well. Upon examination, there may be muscle guarding, a rotated pelvis, and leg length discrepancy. The athlete will have difficulty in forward bending. Modalities can be used such as heat and ice to reduce pain. Mobilization, stretching, and strengthening exercises are implemented to improve alignment and stability. Landing directly on the buttocks or receiving a direct blow can cause injury to the coccyx. Pain, spasming, and difficulty sitting are the common signs and symptoms. Refer the athlete to a physician if the pain persists beyond a few days or the athlete is having difficulty sitting or walking. X-rays and rectal examination and realignment may be necessary. Refer to the textbook for a thorough description of rehabilitation for the cervical and lumbar spine.